Hello, my dear fellow veterinarians. In the last lecture, we were dealing with the diabetes, type 1 diabetes mellitus, and the type 2 diabetes mellitus. What are the different causes for the type 1 diabetes mellitus in case of the canines and felines? Okay, and hope you understood each and everything from the previous lectures. And I discussed what is exocrine pancreatic insufficiency, and what are the complications of diabetes mellitus, how polyuria occurs, how polydipsia occurs, and how polyphagia occurs. Okay, now today in this lecture, this is a very important lecture. So today we are going to discuss about the diabetic ketoacidosis. Diabetic ketoacidosis, since it is one of the complications of diabetes mellitus, mainly type 1 diabetes mellitus, that we will be dealing. Okay, so remember this diabetic ketoacidosis, it is mainly seen in case of the type 1 diabetes mellitus. Okay, why? Because the reason is that in type 1 diabetes mellitus there is the deficiency of insulin. Okay, there is the deficiency of insulin. Why? Because of this deficiency of insulin there occurs the DKA. We will be dealing with this later. I will be making you understand the whole pathophysiology of DKA, so just have a belief. Okay, so you have to remember this is mainly seen in case of the type 1 diabetes mellitus. Okay, what happens that since there is deficiency of insulin, there is severe deficiency of insulin in type 1 diabetes mellitus, what happens that there are some insulin dependent utilization of glucose is deficient. As in the previous lectures I have discussed that how insulin is made, how insulin functions and help us in the transportation of glucose to the tissues and to the cells, and the cells then utilize this glucose for the ATP or energy generation. But when there is deficiency of insulin in type 1 diabetes mellitus, which means that the insulin dependent utilization of glucose is deficient. Means, remember one thing, in the body of humans and in the body of canines and felines there are some tissues that use glucose only at that time when the insulin is present. Means their glucose utilization uptake is wholly and solely dependent on the presence of insulin. Okay, like in case of the brain, in brain the utilization and uptake of glucose is not dependent on insulin. Okay, means when in the diabetic patients what happens that when there is deficiency of glucose, brain can still function, brain can utilize the glucose that is present in the body irrespective of the presence of irrespective of the absence of insulin. Okay, and like in testes can utilize the glucose without the presence of insulin. But there are two main peripheral tissues in human and canine and feline body that utilize glucose only and only in presence of insulin. Okay, what are the tissues? The first one is the muscular system. Okay, the first one is the muscular system. Okay, and the second one is your adipose tissue. First one is muscular tissue. Okay, and the second one is adipose tissue. Means These two peripheral tissues, they utilize glucose only and only in presence of insulin. Like these tissues have special type of receptors that are known as GLUT4 receptors. Okay, and these GLUT4 receptors are susceptible only in presence of insulin, means they function only in presence of insulin. When the insulin binds to these receptors, then this GLUT4 receptors become active, and normally they take the glucose inside and generate energy. Okay, this is the normal mechanism. Similarly, in case of adipose tissues, they have GLUT4 receptors, means they are sensitive to insulin, and when in presence of insulin, they can lead to the intake of this what is called as glucose. Okay, now they can take the glucose. This is the normal mechanism. But since in the type 1 diabetes mellitus, insulin is not present, so what happens in here now? Since there is the deficiency of insulin, so these two tissues, muscular tissue and the adipose tissue, they are unable to take the glucose and utilize it for energy generation. Okay, so what happens here, that since there is the insulin deficiency, so these two receptors, these two tissues won't be able to uptake the glucose and utilize it for energy. In deficiency of the insulin, what happens normally, what happens inside the muscular tissue, this was the normal. Okay, this was the normal. So what happens in the muscular tissue is that it will lead to the proteolysis, means proteins are breakdown of proteins into the amino acids. Okay, now here one thing you have to remember, that everything is happening in the liver. Okay, what will happen, that since these two tissues, they need the glucose, but despite being the presence of glucose in the blood, there is hyperglycemia, as it is diabetes mellitus. But where is the problem is here, that insulin, there is deficiency of insulin and there is no uptake of glucose, but body has to compensate. Okay, means liver has to produce glucose. Okay, but what happens here, this due to the insulin deficiency and uptake of glucose, these proteins are broken into the amino acids, and these amino acids will go to the liver. Okay, and these are used in a process called gluconeogenesis, and through the gluconeogenesis, these amino acids are converted into glucose. Okay, second thing, you know that in the muscles there is the glycogen is present. Okay, but what happens here, that this glycogen, it is not converted into the glucose. Normally what happens, this glucose enters into the this muscular tissue and it is converted into energy. But since muscles have glycogen, it is not converted into the glucose, rather it is converted to a product called the lactate, and this lactate again it goes into the portal circulation in the blood, and through the process of gluconeogenesis leads to the formation of glucose. Okay, since there is increased production of glucose, despite being normal, despite being hyperglycemic state, the liver is further aggravating the condition. It is further increasing the glucose concentration in the blood. Why? Because the muscles undergo the proteolysis and the conversion of glycogen into the lactate. This is one thing. Second, what happens in these adipose tissues? Normally what happens in the adipose tissues, when the adipose tissues take the glucose inside, this glucose is converted into the glycerol. Okay, and this glycerol, normally what happens here, this glucose is taken into the fat cells, it is converted into the glycerol, and this glycerol, it binds with the three fatty acids, and lead to the formation of triglycerides. Means these muscle cells, these fat cells are there is a large concentration of triglycerides present. How? This is the normal mechanism. But what happens when the insulin is deficient, glucose is not uptaken by these adipose cells? What happens? There is these triglycerides, there is lipolysis. Means these triglycerides are converted into glycerol and fatty acids in presence of an enzyme called lipoprotein lipase. Okay, lipoprotein lipase. And this glycerol, it will again go to the this liver and use it in the production of glucose, and these fatty acids also go to the liver and use it in the production of glucose. But remember, when there is deficiency of the insulin, there is such a huge production of these free fatty acids that the liver gets overwhelmed by these fatty acids. And when it gets overwhelmed by these free fatty acids, since normally these fatty acids were not produced. Why? Because the glucose was converted into glycerol, and glycerol used to catch these fatty acids and convert them to triglycerides. But there is deficiency of insulin, glucose is not taken into the adipose tissue, so there will be lipolysis, there will be severe rapid lipolysis. Okay, and in presence of lipoprotein lipase, and these free fatty acids go to the liver and they overwhelm the liver with these free fatty acids. Okay, these extra fatty acids that cannot be used for glucose synthesis. Okay, because liver gets overwhelmed. But now in this state there is one situation. Okay, when the tissues are not getting the insulin, they are not using the glucose, what happens that there is a change in a balance. Okay, what is the balance? When the insulin glucose level goes down, body switches to counter regulatory hormones like glucagon, okay, like cortisol, like epinephrine and growth hormone. Means when the insulin goes down, the concentration of these hormones, it increases, and this ratio means insulin glucagon ratio goes down. Okay, and this ratio, remember, this ratio, decreased insulin glucagon ratio, lipoprotein lipase is very much sensitive to this ratio. Okay, means when there is normal concentration of this insulin in the body, this lipoprotein lipase is not sensitive. Means this pattern, this breakdown will not occur. Okay, in the normal situation. But when there is decreased insulin glucagon ratio in the diabetes mellitus, this becomes hyperactive. When it becomes hyperactive, it leads to the severe rapid lipolysis and leads to the production of these fatty acids, and these fatty acids go to the liver through the process of gluconeogenesis, lead to the production of glucose. Okay, but since there is rapid production of fatty acids, liver is overwhelmed and cannot use the extra fatty acids. And remember, these extra fatty acids are diverted to the ketogenesis. Okay, means these fatty acids will go to the hepatic mitochondria, okay, and will bind to the acyl L-carnitine and into the mitochondria and lead to the production of ketone bodies. So the catch here is that the main thing in the diabetic ketoacidosis is the type 1 diabetes mellitus, and this type 1 diabetes mellitus deficiency of the insulin, these glut receptors are not active, they cannot uptake the glucose. So these two peripheral tissues, this muscular tissue and adipose tissue, they switch to proteolysis and switch to lipolysis and lead to the production of ketogenesis, and there is derangement in, there is decrease in insulin glucagon ratio, and counter regulatory hormones come into play and lead to the increased production of ketone bodies. Okay, now there are three ketone bodies are produced. Okay, the first one is beta hydroxybutyrate. Okay, the second one is acetoacetate, and the third one is acetone. Okay, since this beta hydroxybutyrate, it is the only ketone body that has no ketone functional group. Okay, ketone functional group, mainly in your when you are going to diagnose these ketone bodies in the urine, you mainly use the nitroprusside that strips. You mainly determine these two. Okay, because these two contain the ketone groups. Okay, and you don't this estimate the beta hydroxybutyrate, rather you estimate the acetoacetate, since this beta hydroxybutyrate, it is the product of metabolic product of acetoacetate. So when determining the concentration of acetoacetate, we indirectly determine the concentration of beta hydroxybutyrate. This is examination for your examination point of view, using the nitroprusside these test kits. Okay, which one of the following you determine only acetoacetate and acetone, not the beta hydroxybutyrate. Why? Because it contains no ketone functional group. Okay, and this beta hydroxybutyrate, it is the metabolic product of acetoacetate. But this was the examination for your examination point of view. But what is here, what happens here, along with the production of these three ketone bodies, there is the huge production of protons. Okay, these protons are produced. When the concentration of these protons in the blood increases, it will decrease the pH of blood. It will decrease the pH of blood, means there will be acidosis. Okay, what sort of acidosis? Metabolic acidosis. Remember, in diabetic ketoacidosis, what sort of acidosis occurs? It is metabolic acidosis. Okay, why? Because there is increased production of protons during the process of ketogenesis, and these protons, they decrease the pH of blood. How they decrease the pH of blood? Let us see. You know, in order to maintain the normal pH of blood, there is a buffer system in body, that is the bicarbonate system. Okay, when there is increased production of protons, these protons will combine with, they react with these bicarbonate ions and lead to the production of carbonic acid, and this carbonic acid later breaks into carbon dioxide and water. Okay, when there is increased production of protons, okay, it will increasing production of protons will increasingly consume these bicarbonates. Okay, are you getting me? When there is, suppose there is 10 protons are produced, okay, and it will consume the 10 carbonates. Similarly, when there is increased production of these protons in ketogenesis, it will further consume these bicarbonates. So there will be increased production of this carbon dioxide, and this carbon dioxide is pumped out of lungs. So in diabetic ketoacidosis, you will see a typical type of respiration that is known as Kusumal's respiration. Kusumal's respiration. Okay, what is Kusumal's respiration? You will see the inspiratory drive is more, like, means the inspiratory drive is more deep. Okay, this is typical in diabetic ketoacidosis. And this hyperventilation means this the increased removal of carbon dioxide is a compensatory mechanism to this metabolic acidosis. Okay, so whenever you are dealing with a case of diabetes mellitus and diabetic ketoacidosis, this is one of the, you will see that there is Kusumal's respiration, means there will be deep inspiration and shallow expiration. Okay, so this you have to remember. Now one thing you have to remember here, that since there is metabolic acidosis and pH of the blood decreases, but one thing important here is that this acetone it leads to the sweetish, it is also removed through lungs and leads to the sweetish fruity smell. Okay, so when you are dealing with a case of diabetic ketoacidosis and you are smelling the breath of the patient, you will see that there is the sweetish breath smell. Why? It is because of the acetone is also removed through lungs. And one thing, when you go for arterial blood gas analysis, okay, what you will see, that in a patient, comes to you, the patient is, there is a complaint of vomition, there is a complaint of lethargy, okay, there is complaint of altered stupor, and then you it's a case of diabetes, type 1 diabetes mellitus. Okay, so you will also there is the previous this diabetes mellitus, there is increased there is hyperglycemia also seen in case of the lab tests. Okay, then you will go for the ABG analysis, arterial blood gas analysis. In the ABG, when you will see that the pH is less than 7.4. Why pH will be less than 7.4? As I already discussed. Okay, increased concentration of the protons. Okay, so bicarbonates, what will be the bicarbonate? It will be less than 12 milliequivalents per liter. Okay, why bicarbonates will be less? As I already told you, as I already made you understand, that this protons go on consuming this bicarbonate. Okay, so the bicarbonate concentration will be decreased, mainly less than 12 milliequivalents per liter, and ketone level will be more than 5 millimoles per liter. Okay, and blood glucose, when you are going to see the blood glucose, it will be more than 600 mg per dl. So when you are getting the ABG of that animal and you experience such things, pH less than this, bicarbonates less than 12 units, and ketone this, diagnose it a case of diabetic ketoacidosis. Okay, so this thing you have to remember. So in a DKA dog and cat, pH will be less than 7.4, bicarbonates will be 12 milliequivalents per liter, and ketones will be more than 5. How pH decreases, how bicarbonate decrease, and how ketone bodies are formed, so I already explained each and everything. Now one more thing that you are going to see in the DKA patients, that will be dealing separately in the in a while. Normally in our body, in cells, there are special type of receptors. Okay, the receptors are known as potassium hydrogen exchangers. Okay, normally what happens, that normally the potassium concentration inside the cells is more. Okay, this is the normal. Okay, and this hydrogen concentration inside, this is the normal state. Okay, inside the potassium, this is in the normal state inside the cells, and outside the cells, potassium, this hydrogen in the normal state. But whenever there is acidosis, okay, I already explained it, that there is metabolic acidosis, there is increased concentration of hydrogen ions. Okay, there is increased concentration of hydrogen ions. So what will happen, these potassium hydrogen exchangers will become active, so they will lead to the increased intake of potassium inside the increased intake of protons inside the cells, and in exchange of the protons, the potassium will be released. Okay, so the potassium will be released in the blood, so it will lead to a state of hyperkalemia. So it will lead to a state of initially there will be a state of hyperkalemia. Okay, but later on, since later on this hyperkalemia, there will be osmotic diuresis because of the increased glycosuria and ketonuria. This potassium is removed through the urine through urinary loss, so it will lead to the hypokalemia, that we will be discussing in the later. But here one thing you have to remember, that when you are going to treat a DKA patient, remember it is not hyperglycemia that kills the patient, rather this is the hyperkalemia. Why? Because when you are going to give the insulin, okay, what happens that normally the doctors who are treating the patients, they go for the increased dosage or the rapid administration of insulin. What will happen? There will be this insulin has a counter effect. What happens that in the treatment portion I will be discussing each and everything here, just to make you understand that how hyperkalemia kills the patient. Okay, insulin will lead to the increased, since the most of the potassium is in the blood. Okay, so there is hyperkalemia. When we give the insulin at a larger dose, it will lead to the rapid influx of potassium back into the cells, so there will be rapid production of hypokalemia. When there will be rapid production of hyperkalemia, it will lead to the this hyperpolarization and death. So when you are going to treat a patient of DKA, never give a high and a rapid dose of insulin. Okay, first give fluid resuscitation, okay, stabilize the animal, then after that give the insulin, and then the electrolyte, maintain the electrolyte balance. Okay, so this you have to remember now. So this is the, so you are aware now about what happens in the diabetic ketoacidosis, how these ketone bodies are produced, how the peripheral tissues are reacting, what happens to the CRH, that is counter regulatory hormones, so everything, Kusumal's breathing and all that. So what are the this correct snapshot lab diagnosis in case of the DK, and what happens to the potassium level. Now what will happen to the sodium? Now this is important. What will happen to the sodium? Remember one thing, I have to make you remember here. Remember one thing. This you have to remember. Okay, this is for your examination point of view, that what are the common clinico-pathogenic abnormalities identified in dogs and cats with DKA, diabetic ketoacidosis. First, now we are going to discuss that there is hyponatremia. There is written here that hyponatremia is seen in case of the DKA patients. Let us discuss it, how hyponatremia occurs. Remember, when in case of the DK, diabetic ketoacidosis, since there is hyperglycemic state, okay, means glucose is, there is increased concentration of glucose in the blood. What are the reasons? First, there is insulin deficiency. Second one is the liver is producing more glucose. Okay, that I already discussed in here, that despite being the normal concentration of glucose in the blood, liver is further increasing the glucose. It is aggravating the condition. It is further increasing the glucose through process of gluconeogenesis and glycogenolysis. So there will be increased concentration of glucose in the diabetic ketoacidosis. Okay, second, there is ketonuria, means ketone bodies are present in the urine. So both these conditions, hyperglycemia and ketonuria, means glycosuria, presence of glucose in the urine, and ketonuria, presence of ketone bodies in the urine, they lead to the osmotic diuresis. Okay, they lead to the osmotic diuresis, and because of the osmotic diuresis, there is excess sodium urinary loss, means sodium is excreted through the urine, so that will decrease the sodium concentration in the blood. This is one of the reason why, because of the glycosuria and ketonuria. Second one is that normally insulin is important for renal sodium absorption in distal convoluted tubule. Okay, so this is the normal. Okay, but in diabetes mellitus there is deficiency of insulin, means insulin is not present, so there will be decreased renal absorption in the distal convoluted tubule, so that will further lead to the hyponatremia. Okay, so in DKA there is hyponatremia. The reasons are osmotic because of ketonuria and glycosuria. Second, insulin normally leads to the renal sodium absorption in the TCT, but since there is decreased insulin concentration, that will lead to the decreased renal absorption, renal sodium absorption in TCT. The third one is there will be vomission. Vomission further will lead to the sodium, decrease the sodium concentration. So these are the three reasons that lead to the hyponatremia in DKA patients. Okay, so now remember here one thing, that for every 100 mg per dl, okay, of plasma glucose above the reference range, plasma sodium concentration decreases by 1.6 milliequivalents per liter. Means if the normal concentration of glucose in the canine and feline body is normally it is 75 to 120 mg per dl. Okay, this is the normal glucose concentration. So when there is for every 100 mg per dl of plasma glucose above the reference rate, means if it now becomes 120 is the highest range, added by 100, okay, it will become 220. Means when it increases by 100, of the upper limit, means it becomes the 220 mg per dl, so it will lead to the 1.6 milliequivalents of, it will decrease the sodium concentration by 1.6 milliequivalents. Okay, so this you have to remember. Based on this, there is a formula, okay, that will help you in your clinics to calculate the how much sodium I have to give to this diabetic ketoacidotic patient. Okay, the formula is corrected sodium that you have to give is 1.6 to measured glucose measured in mg per dl, okay, minus 100 divided by 100 plus measured sodium. So this will help you in how much sodium you have to give to a diabetic ketoacidotic patient. Okay, so this will also help you in calculating how much sodium will be decreased. Okay, if it becomes 330, it will be twice. Okay, if it will become 4 plus 100, it will become 430 thrice. Okay, this will go on decreasing, means with every 100 mg per dl of plasma glucose above the reference range, plasma sodium concentration will decrease by 1.6 milliequivalents per liter. So this is how this hyponatremia occurs. Okay, now the second is serum potassium. So here there occurs hypokalemia. Now how this hypokalemia occurs in DKA patients? Remember, in DKA patients, I already told you that initially there is hyperkalemia. How there is hyperkalemia? It is that I explained each and everything. But later on, what will happen that since due to the this potassium, it follows the water. Okay, since there is the increased tonicity of the extracellular fluid, there is the increased production of this ketone bodies and glucose. Since these ketone bodies and the glucose These lead to the increased osmolality of the extracellular fluid and lead to the drag and will drag the water. Okay, and along with the water, potassium also follows. So when there will be this water will be, there will be osmotic diuresis, means there will be increased urine water loss through the urine. Same, the potassium will also follow. That will lead to the hypokalemia. But remember, initially there is hyperkalemia. This hypokalemia, this is very important in the management of the DKA, and based on this hypokalemia, there is a special this ECG findings are seen in the DKA patients. So let us have a look. Okay, so you can see here that this is the normokalemia when the concentration is 4.5 milliequivalents per liter in the dog and cat body. This is the normal. Okay, so this is the T wave is normal. So when there is moderate hypokalemia, means the serum, this potassium level decreased to 2.8 milliequivalents level. So here you will see that this ST segment is depressed, means the T wave is somewhat depressed, and there is the presence of the U wave. What is U wave? When we will be dealing with the ECG, I will make you understand that normally this is the P, this QRS complex, this is T wave, and this is the U wave. What is the U wave? U wave occurs because of the delayed this repolarization of the papillary muscles. Okay, when there is delayed repolarization of the papillary muscles, there is the presence of U wave. So this is for your examination point of view. In case of the DKA patients, what you will find, when there is the presence of this hypokalemia, maybe it is, whether it is moderate or severe hypokalemia, you will see the U wave. Okay, this is the pathological U wave. Why U wave occurs? Because there is the delayed repolarization of the papillary muscles. Okay, since there is the delayed repolarization of the papillary muscles. Okay, papillary muscles of heart. And since you know that potassium is important for when we will be dealing with the electrical activity in the heart and the use ECG, how this potassium leads to the repolarization, means ventricular repolarization. So we will be dealing in the separate lecture of the ECG. So these are the ECG findings, means you will see the presence of U wave and ST segment will be depressed and there will be wider QRS complex. So you will be seen in DKA patients. So this will be with the serum potassium. Third finding in case of this will be what will happen with the blood urea nitrogen and creatinine. Here you just have a look that there will be increased blood urea nitrogen and serum creatinine. Why? Because you know that because of the osmotic diuresis there will be dehydration. Okay, means whenever there is increased blood urea nitrogen and creatinine, there are azotemic conditions in the DKA patient. Okay, there will be, we call it as pre-renal azotemia. Pre-renal azotemia means the kidneys will be normal, despite kidneys being the normal, there will be increased blood urea nitrogen and creatinine. Okay, it will simply indicate volume depletion, means there will be dehydration. Why? Since I made you understand in the previous lecture that there will be, because of the osmotic diuresis, there is this polyuria. Because of the polyuria there will be excessive dehydration, and because of the excessive dehydration there will be increased blood urea nitrogen and creatinine. Okay, but one thing you have to remember here, that when you go for fluid therapy, okay, when you go for fluid therapy, that will be dealing in the treatment part. If the blood urea nitrogen and creatinine is rapidly falling, okay, is rapidly falling. For example, you before the treatment you went for the blood urine nitrogen creatinine analysis, and after the fluid therapy you again this go for the blood urine nitrogen and creatinine analysis, and you found that the BUN and creatinine is rapidly falling. Okay, in azotomic dog. Okay, it is rapidly dog and cat, it is rapidly falling. It means that there is the fluid therapy is proper, means your fluid therapy is working and the urine output is good. And what is important here, that it will help you, in diagnosing that it was the pre-renal azotemia. So you have to remember, means what I want to convey, that after the fluid therapy you found that this is a case of DKA, diabetic ketoacidosis, and you found that blood urine nitrogen and creatinine is increased. Then you went for the fluid therapy. Okay, so in the fluid therapy, before the fluid therapy you took a blood sample and went for the this BUN and creatinine analysis, and after that you found that there is the rapid drop in the concentration of these two molecules. So if there is rapid drop, it will help you in diagnosing that this was a case of, this is actually pre-renal azotemia. Okay, and the kidneys are working properly, there is proper urine output. Okay, so second, there will be this consequence will be that if it is slowly falling. Okay, so remember, the azotemia is because of the primary kidney failure. So it will help you in differentiating these two conditions. Okay, so this is the blood urine nitrogen, what happens to the potassium, what happens to the sodium in DKA patients. Third is what will happen to the serum osmolality. Serum osmolality. Okay, since you know that because of this glycosuria, ketonuria, there is hyperosmolality. Okay, and in DKA patients this hyperosmolality is responsible for the CNS dysfunction and altered consciousness. Means you are getting this DKA patient, and the DKA patient, this is having altered consciousness, means it is having altered stupor. So the main reason behind it is that there is hyperosmolality, and a special type of consciousness is seen in case of the dogs and cats, in case of the DKA dogs and cats, because of the increased serum osmolality, and that is known as clouded consciousness. Okay, it is seen in DKA dogs and cats. The reason is increased osmolality. Okay, but fortunately in DKA dogs and cats, okay, this severe hyperosmolality has never been found. Okay, so there is a reason why in case of the DKA dogs and cats there is never this hyperosmolality has been found. Okay, normal this osmolality, serum osmolality in dogs and cats is 280 to 300 milliosmoles per kg water. Okay, this is the normal. So when it is more than 350 milliosmoles per kg of water, we call it as hyperosmolality. But this hyperosmolality has never been seen in case of the DKA dogs and cats. What is the reason? Let us discuss the reason. I told you earlier that first you just remember one thing. The serum osmolality is because of two molecules. One is sodium. This is largely responsible. Okay, means sodium mainly determines the serum osmolality, and to a lesser extent glucose. Okay, these are known as effective serum osmolality determining molecules. Means these two determine the serum osmolality. Means mainly out of these two, the sodium it is largely determining, and glucose it is to a lesser extent determining. And what about this potassium and urea? These are known as ineffective osmoles. Why? I will be dealing with why these are called ineffective osmoles. I will be discussing it later. So why there is never seen the case of hyperosmolality in case of the DKA dogs and cats. Mainly, I told you, in DKA dogs and cats there is always seen a situation of hyponatremia. Means the sodium concentration is low. Okay, when only in DK, remember, in DK dogs and cats there is hyponatremia. DKA dogs and cats, when there will be decreased sodium concentration, the sodium concentration will be decreased. This is consistent finding in case of the DKA dogs and cats. So serum osmolality will not be increased. Okay, since 90% of serum osmolality is determined by sodium. Normally, if the sodium concentration is 140 milliequivalents per liter, so in DKA patients it will be 120 milliequivalents per liter. So it will not lead to the increased osmolality. Okay, so this is the reason, because of the hyponatremia. Okay, so this is the reason. And why these potassium and urea are ineffective osmoles? Why they are not determining the serum osmolality? Because cell membranes are permeable to these. Because the cell membranes are permeable to these molecules. What I want to convey that normally, in order to determine the osmolality of the extracellular fluid, the main thing is that which molecule is creating the tonicity. Okay, which molecule is able to create the gradient. So if some molecules like the potassium and urea, they are freely moving through the semi-permeable membranes, through the cell membranes, are they able to create the gradient? No, they are not able to create the gradient. So which molecule is able to create the gradient across the membranes? That is the sodium and glucose. That's why these are called the effective osmoles. Okay, so this you have to remember. And when there is increased this hyperosmolality, so there will be I will be dealing in the treatment part. We go for IV fluid, isotonic fluid therapy, and insulin. That will be dealing in the next lecture. So in sophisticated these labs and clinics, normally there are equipments that determine this osmolality of the serum osmolality. But if you are not having that equipment, I will provide you a formula that will help you in determining the effective extracellular fluid osmolality. Okay, means the effective extracellular fluid osmolality, milliosmoles per kg of water, it will be equal to twice the sodium concentration plus 0.05 glucose. Glucose is measured in mg per dl. Means if you are having this sodium concentration and you are having the glucose concentration, it will give you the effective ECF osmolality. Okay, or if this is in this is when the sodium concentration is this milliequivalents per. If you want to get this sodium concentration, if you are having the sodium concentration in milliequivalents per liter, or there is another formula, that is twice the sodium, okay, plus if you are having glucose in millimoles per liter. Okay, here you just remember, it's not, if you are having glucose in mg per dl, then use this formula, twice sodium plus 0.05 into glucose mg per dl. If you are having glucose in millimoles per liter, then use this formula. Okay, means you have to delete 0.05 in this formula. So it will help you in this monitoring the what is the ECF osmolality in DKA patient. Okay, so this, hope you understood this osmolality part. Now another finding in the DKA patients is the anion gap. Now I told you earlier that there is metabolic acidosis. In case of the diabetic ketoacidosis, there is metabolic acidosis. First, let me discuss a bit what is anion gap. You may be already knowing this, but in order to clear the concept, let us have a recap of this. You know, mainly the anion gap, we mainly go for, we subtract, okay, we subtract anions from major anions from cations. Okay, this will give you the anion gap. Normally in dogs and cats, the anion gap is 12 to 16 milliequivalents per liter. Okay, remember one thing, you have to remember, when the anion gap is more than 16 milliequivalents per liter. Okay, means when the anion gap is more than 16 milliequivalents per liter, it will be known as anion gap acidosis. Okay, it will be known as anion gap acidosis. So one thing you have to remember here, that in DKA, diabetic ketoacidotic dogs and cats, the anion gap that has been found is 20 to 35 milliequivalents per liter. You have to remember for your examination point of view as well as for your this clinical approach. So remember one thing, that suppose what happens in normally, let me make you understand why when the anion gap increases, it leads to anion gap acidosis, and it decreases, it leads to the anion gap alkalosis. Let me make you understand. Okay, normally what happens, suppose if you are going to anion gap calculating, suppose the sodium concentration is 140 milliequivalents per liter. Okay, the potassium is 4 milliequivalents per liter, chloride is 105 milliequivalents per liter, and this normal bicarbonate is 24 milliequivalents per liter. Okay, so this will give you 15 milliequivalents per liter anion gap, and this is normal. Okay, so normally normal serum sodium concentration is 140, normal potassium concentration is 4 milliequivalents, normal chloride concentration is 105 milliequivalents per liter, and normal bicarbonate is 24. So the anion gap, if you are calculating it, anion gap will come out as 15 milliequivalents per liter, and I told you here that the normal is 12 to 16. So this is the normal anion gap. Now earlier I told you, if you are just recalling my 10 to 15 minutes back, I told you that due to the increased production of protons, okay, due to increased production of protons in the process of ketogenesis, these protons consume the bicarbonates. Okay, these go on consuming the bicarbonates, means the bicarbonate concentration in the body is decreasing. So if here suppose if we consider this situation, that in the DKA patient, if we consider the diabetic ketoacidotic patient, and we know that due to the increased production of protons, the bicarbonate concentration will be less, so it will be, suppose it will be 12. Okay, since it is normal is 24, now it will be 12. So if we will calculate the anion gap ratio, it will be sodium will be 140, potassium will be 4, minus this chloride will be 105, and this it will be 12. Okay, so if we go on calculating the, if we go on, so what will be the this anion gap now? What I want to make you understand that in diabetic ketoacidotic patient, there will be this bicarbonates will be less, concentration will be less, because increased production of proton. So after considering the decreased production of this, decreased concentration of bicarbonates, what will happen to the this anion gap? It will come out as 27, means the anion gap is increasing. And here I told you that when the anion gap is increasing, it will lead to the ketoacidosis. So it will lead to the this acidosis. So it will be anion gap acidosis. Are you getting me? So I want to clear my concept. I want to this check my concept. I earlier told you that increasing the anion gap, this when there is when there is increased anion gap, okay, so it means it is acidosis, anion gap acidosis. Okay, no, so now here I considered this bicarbonate to be decreased. I want to check my this claim that I now I consider that the this bicarbonate is 12 milliequivalents per liter. Why? Because in diabetic ketoacidosis, these protons are consuming these bicarbonates. So when I put this bicarbonate 12 into the formula, it came out as 27. So when it is more than 16, it means it is anion gap anion gap acidosis. So it is 27, it means it is anion gap acidosis. So hope you understood this concept, that how it leads to the anion gap acidosis. The reason is that there is depletion of bicarbonate. And remember one thing, that it is hyperchloremic acidosis. What sort of anion gap acidosis? Hyperchloremic acidosis. This is important. How this hyperchloremic acidosis? The reason is that since in the body, what happens that normally what happens, you just look at the formula here. In the diabetic ketoacidosis, when the bicarbonate is gone decreasing, okay, so since the chloride in proportion to the bicarbonate, the chloride concentration will increase. That is why it lead to the hyperchloremic acidosis. Okay, so this is the reason. So hope you understood this. But this anion gap acidosis in DKA patients, this anion gap acidosis, it must be differentiated from the causes of anion gap acidosis. Okay, so let me show you what are the other causes of anion gap acidosis. So remember, increased this anion gap in diabetic ketoacidosis, it is seen. In lactic acidosis, it is seen. Okay, in uremic acidosis, it is seen. It is in dogs and cats. Okay, dogs and cats. In ethylene glycol intoxication, it is seen. In salicylate intoxication, it is seen. So normal anion gap, it is seen in diarrhea, renal tubular acidosis, hypoadenocorticism, hyperchloremic acidosis, ammonium chloride, and carbonic anhydrase inhibitors. And one thing you have to remember, that when you give 0.9% normal saline, at that time this this hyperchloremic acidosis, it is seen in also in DKA plus when you give 0.9% normal saline. We will be dealing it in treatment part, how it also leads to the this hyperchloremic acidosis. So these you have to remember, what leads to the increased anion gap and normal anion gap. And here in DKA there is anion gap acidosis, how it occurs, and how hyperchloremic acidosis occurs. So this is regarding the these serum parameters, what happens to the serum parameters in the DKA. So now we will discuss what happens to the hematology of DKA patient. So you send the blood sample to the lab and get the CBC. So in the CBC you will see neutrophilic leukocytosis. You will see the neutrophilic leukocytosis. The reason is maybe the patient is under stress. Okay, there will be some sort of inflammation, like maybe there will be pancreatitis. Okay, there will be pancreatitis. Okay, so these are the reasons, or there will be some sort of infection, since the this glucose is present in the urine, and glucose is the best substrate to the bacteria, so it will lead to the neutrophilic leukocytosis. Mainly the WBC count will be more than 30,000 per microliter. Okay, and when you will go for the cytology, you will see degenerative neutrophils. So this is the CBC, and there will be left shift. Mainly you will see immature. Okay, you will see immature. This left shift towards immaturity of cells, immature neutrophils. Second, hematocrit PCV will be less than 35%. Why? Since there is volume depletion, there is a lot of dehydration because of the osmotic diuresis. So this will be in the hematology. Okay, what will happen to the liver enzymes? Since I told you there is the extra production of this extra overwhelming of the liver by these fatty acids, so it will lead to the commonly seen hepatic lipidosis. Okay, so you will normally see in this liver function tests, you will see increased ASTs, you will see increased ALTs, phosphates and bilirubin. Okay, it will all will be increased. You can also remember them from this chart that I already provided. Here. Okay, so there will be neutrophilic leukocytosis, hemoconcentration, hyperglycemia, hypercholesteremia. Okay, increased alkaline phosphatase activity, increased alanine aminotransferase activity, there will be metabolic acidosis, there will be hyperosmolality, there will be glycosuria, there will be ketonuria and urinary tract infection. Okay, and when you are dealing with the DKA patient, always go for see also the status of pancreatic enzymes. Okay, mainly because in DKA dogs and cats pancreatitis is common. How will you diagnose pancreatitis? There will be epigastric pain, there will be vomition. Okay, and with the help of ultrasound you will be diagnosing it a case of pancreatitis, and with the help of these two enzymes, one is canine pancreatic lipase and feline pancreatic lipase. These two will help you in diagnosing the case of pancreatitis. Okay, so this is pancreatic enzymes. So what will happen to the calcium, phosphorus and magnesium? Normally, if it is a case of, if it is an uncomplicated DKA case, okay, means the kidneys are not involved, there will be normocalcemia, means the calcium level will be normal. Okay, but serum calcium and phosphorus, there will be normocalcemia and normophosphatemia, means both the calcium and phosphorus will be normal in uncomplicated DKA patients. What are uncomplicated DKA patients? Means no renal involvement. Okay, in primary kidney disease patients, these are the comorbid DKA patients, means DKA patients with also renal failure. you will see that the serum calcium will be normal, but the serum potassium will be increased. Okay, it will be increased. So this you have to remember. So when we will be dealing with the treatment of this, how to deal with the increased serum potassium, we mainly give the insulin, and insulin leads to the translocation of potassium from extracellular fluid to the intracellular fluid. So this at that time you have to take the cautions, because giving the insulin at a larger dose will lead to the rapid this uptake of phosphate from extracellular fluid to the intracellular fluid, and it will rapidly decrease the phosphate level in the blood. Means that will be dealing in the, what I want to say that in the therapy, when we give the larger doses of insulin, okay, what will happen? Insulin will, this is extracellular fluid, this is intracellular fluid. In normally in DK patients, phosphates are present in larger concentrations in the extracellular fluid, but giving the insulin, it will take the phosphate back to the intracellular fluid. If we give the larger doses, it will rapidly take this phosphate from the extracellular fluid to the intracellular fluid, thus creating a deficit of phosphates in extracellular fluid. And when this deficit is less than 1 mg per dl, okay, so it will lead to the what we call as hemolytic crisis. You will see there will be bleeding, okay, there will be bleeding. Why? Since this phosphorus is important for RBC, this stability of the RBC membrane. When this decreases less than 1 mg per dl, it will lead to the fragility of RBCs. So it will lead to the acute hypophosphatemia and will lead to the hemolytic crisis or hemolytic anemia. So giving the insulin for the DKA patient is not everybody's cup of tea. You need everything or panel, okay, you need to monitor each and everything, and after that give the insulin dose. We'll be discussing each and everything about this management in the next lecture, how to give the insulin, what sort of dose you should give, what to consider first. But here I want to make you understand that how this insulin therapy, in spite of treating the animal, it will lead to the death of the animal. One condition is that that I earlier discussed, that how it leads to the hypokalemia, okay. So in here, how it leads to the hypophosphatemia. So you have to cautiously, you have to treat the DK patient, okay. What will happen to the magnesium? You know that since there is, in case of the DK patient, there is huge osmotic diuresis, and this magnesium is this there is urinary loss of magnesium, and it will lead to the hypomagnesemia. So again, the cause of hypomagnesemia is osmotic diuresis. So hope I made the justice with this TKA. So in the next lecture, we will be dealing with this management and treatment of TKA, and after that we will be dealing with the macrovascular complications, that diabetic retinopathy, neuropathy, nephropathy, and this osmotic syndrome. So we will be in the next lecture, mainly we will be dealing with HHS syndrome and macrovascular complications, and after that this the general treatment management of diabetes mellitus in canines, and separately in the felines. It will take us 3 to 4 lectures, and hope this will clear all your doubts regarding the diabetes, since mainly what I feel that this medicine part in canines and felines is very much neglected. Mainly in our graduation, we don't give too much this effort to understand this medicine. In case of the swine, it is such a beautiful subject. When you are having a lot of concepts clear, it will give you a lot of confidence in treating these typical cases, that in the future you will see that veterinary medicine will be at a bloom, okay, it will be at par with the medical science. So you should be very much ready in order to combat the future, and for your examinations like NAVLE and other examinations. So these lectures are very much up to date to combat the horizons of those examinations. I hope you will help me in this in making this series successful, just by subscribing, and also share with your friends, to the new graduates that are in their graduation, and to the other this veterinary fellow veterinarians, so that as a community we will grow as good veterinarians. Okay, so in the next lecture we will be dealing with the management of diabetic ketoacidosis. Any question or any confusion, kindly jot down in the comment section. Thank you so much.